Thank you for inviting me to take part in the conference today. My name's Tom Wainwright. I'm Professor in Orthopaedics at Bournemouth University. I'm a physiotherapist by profession and have been involved in enhanced recovery, either in a clinical, managerial or academic role for over 15 years. Today I've been asked to talk to you about the application of enhanced recovery in shoulder arthroplasty and reflect upon what we can learn from its implementation in hip and knee replacement and where the direction of travel is for the future. So in my presentation today, I'm going to be talking in broad terms about enhanced recovery for those of you unfamiliar with the concept, its underlying principles and components. I'm then going to talk a little bit about the outcomes and the specifics of enhanced recovery or ERAS or rapid recovery in hip and knee replacement. And then I'm going to talk about what we know so far about from the publications in shoulder arthroplasty. And then at the end, talk a little bit about implementation and perhaps some tips and tricks that we can learn from how we've implemented in hip and knee replacement that hopefully we can learn from and accelerate the spread within shoulder arthroplasty. One thing I'm not going to tell you to do is that I'm not a shoulder surgeon and my experience is across enhanced recovery and across improving pathways in orthopaedics, but we'll talk in general concepts today. But firstly, if we go back, my journey in enhanced recovery started as manager of the orthopaedic department at the Royal Bournemouth Hospital back in 2007, where at that point we had a massive waiting list and the 18 weeks came in from the Department of Health. And we, in a period of 3 months, completely changed our pathway and adopted enhanced recovery principles and went from a length of stay of around 8 days down to 4 days within 3 months. Now, this dramatic change was then, sort of at the top of the country at that point. And that's really where my interest in enhanced recovery started. But actually what's interesting is how we've almost come full circle now with the elective surgical backlog after the COVID-19 pandemic. And we're going to need to optimise our surgical pathways in the coming months and years. So where did enhanced recovery start? Well, for those of you who are unfamiliar, Henrik Kellett is a professor and GI surgeon from Copenhagen in Denmark. And in the late 1990s and early 2000s, he started revolutionising perioperative care for general surgical patients. He defined enhanced recovery as an evidence-based approach to care. It was designed to prepare patients for reduce the total impact of surgery, helping them to recover more quickly. It's a multimodal approach similar to that of care bundles. And what he did back in the late 1990s, he questioned all the traditions. Why did they starve the patients before and post-surgery? Why were they using a big general anaesthetic, a big slug of opiates and large surgical incisions? And he looked at the evidence-based and transformed the outcomes for his patients, both in terms of length of stay and complications post-operatively overnight. And underlying all of this is an approach to reducing or modulating the surgical stress response. So Kellett looked in a multimodal effect to minimise the infarct from surgery so that patients could recover quicker, and did this through an opioid-sparing analgesic and anaesthetic approach. A return to early hydration, feeding and mobilisation post-surgery, and a move to more minimally invasive surgical techniques. And he asked 3 questions, and these questions are still pertinent to now. They've been pertinent in hip and knee replacement, and they'll be extremely important as we look to spread it to other procedures within orthopaedics, such as shoulder and elbow surgery. And he asked, how can we achieve the goal of a pain-free and risk-free surgery? And whilst that may never be fully achievable, it should always be our goal. And underpinning that, he said, can every operation be ambulatory or a day case? Why is the patient still in hospital today if they stayed longer than a day case? And what factors could we not control? What factors were sort of things that we couldn't control? The sort of emphasis there being we can control a lot more things than we think we can. And so enhanced recovery as a concept is underpinned by this multimodal and crucially multidisciplinary intervention. At the preoperative stage, we have thorough assessment and optimisation, as well as preoperative education and counselling around early mobilisation and length of stay. Within the surgical aspect, we have attenuation of the surgical stress response, tissue sparing, minimally invasive approaches where appropriate and where evidence-based, but also a maintenance of normothermia, maintenance of fluid balance, and also all the general modern surgical principles of antibiotics, etc. Pain relief is multimodal and opioid sparing, so that we save ourselves the complications associated with giving opioids to our patients. And use mobilisation as an analgesic intervention and also an intervention for getting patients up and going as soon as possible after surgery, along with, of course, oral and early feeding and nutrition and water. And all of this leads to an accelerated post-operative recovery and reduced morbidity for our patients. So what does that look like within hip and knee replacement? Well, hip and knee replacement has drastically changed over recent years, and we now are routinely seeing for some patients, even within the NHS, day case hip and knee replacement surgery, which 10 to 15 years ago we were miles away from. But routinely, patients are discharged between 1 and 3 days in lots of hospitals. Although in many NHS hospitals, patients still stay around 4 days, as we'll see in a moment. And the principles of enhanced recovery within hip and knee replacement are based around preoperative education and counselling. There still lacks convincing evidence for routine prehabilitation in all patients. Research in the future may indicate where it's more relevant to specific patient groups, such as the sarcopenic or frail and elderly, or those that are high pain responders that may need more psychological interventions preoperatively to reduce their anxiety and reduce their likelihood of chronic pain post-discharge. Smoking and alcohol cessation in accordance with local guidelines. Anemia screening at the preoperative stage so that it can be optimised. Routine fasting guidelines in accordance with the latest surgical practice, and prevention of post-operative nausea and vomiting as is standard practice now. What's interesting here, and we'll talk more in a moment about the standard anaesthetic protocol, multimodal opioid-sparing analgesia. Strategies to prevent blood loss we'll talk about in a moment, such as tranexamic acid, and the use of not using drains and removing catheters and all of those things as soon as possible, or not using them at all, and early mobilisation as a key aspect. And these guidelines are explained in detail in the recent document published in Acta Orthopaedica. But what I'd like to touch on now are the real active components, which I see as the bedrocks around enhanced recovery and hip and knee replacement. What's clear in all the exemplar units is a standard anaesthetic protocol, so a move from general anaesthesia to regional anaesthetic techniques, and combined with a multimodal opioid-sparing analgesic regime. Now, what's not clear is the absolute cocktail that's included within this, and that differs slightly from exemplar unit to exemplar unit. But what is consistent is that they use standardised approaches, and this is extremely important for clinical teams so that they can understand when pain is not controlled and progress and give increased medication, or they can understand when to reduce medication. And nurses and physios understand when they're going to be able to mobilise patients. It's not just enough for the patient to be pain-free, this has to be combined with appropriate anaesthetic so they can mobilise early in a safe way. Also, we've got unequivocal evidence to support the routine use of tranexamic acid now in hip and knee replacement, and this is developed over the last 10 years. Again, there are differences in protocols and regimes and how that tranexamic acid is delivered, but a bedrock of all enhanced recovery pathways is its use to prevent blood loss. And lastly, early mobilisation. This is a fundamental and is key. And processes and systems need to be changed in order to facilitate it. Extended working hours for physiotherapy, changing in staffing rotas, managing patient expectation and staff expectation that this will happen for all patients are extremely important. If you don't mobilise the patient within a few hours of surgery, you've got no chance of them going home on the day of surgery or the first or second day after that. What's interesting when we look at the literature is how we look at the importance of surgical technique. In this article we published some years ago now, we couldn't find any distinct role for minimally invasive proof that would accelerate the achievement of discharge criteria any more than proven traditional incisions and techniques. And although many of the companies and many research pins an enhanced recovery approach alongside a different approach, say for hip that may be anterior approach versus the posterior approach, it may be minimally invasive techniques or navigation or robotic surgery. If you look against all the literature and in published cohort series from big centres, you can achieve day case surgery, such as they are at Northumbria for one example, with standard techniques. What's crucial, of course, is that when we're choosing these surgical techniques, we're thinking of survivorship and longevity of these implants. And I think this is important because actually for enhanced recovery, it's more the anaesthetic, nursing and physiotherapy changes around the surgical event which can really make the changes in the short-term functional recovery and reduction of length of stay. So, in summary, ERAS has been, or enhanced recovery has been hugely successful over the last 10 years in reducing length of stay, reducing readmissions or showing no increase in readmissions in those centres with already low rates, reduce complications, reduce mortality and also reduce improvements in patient-reported outcome measures and patient experience measures, and also economic savings as well. But we've got future challenges if we are to achieve our goal of a pain and risk-free surgery. We still need to understand more about the pre and post-op reduction of the inflammatory response, solve problems in knee replacement for the subacute and persistent pain in patients, and therefore optimise our opioid-sparing analgesic strategy for these groups of patients. I think we can better identify high-risk patients so we can reduce chance of complications, and we may need to think about how we further refine anemia and transfusion thresholds, accordance with local policy, but also managing the patient in the most effective way. We also need to see about how we can expand the feasibility of outpatient surgery for more patients and what that may look like without changing discharge criteria. And from a professional perspective for me, we can still optimise further the type, timing and duration of physiotherapy, specifically for those groups of patients that may need more input post-discharge, because undoubtedly we could still further improve return to function quicker following surgery. Now, can all hip and knee replacements become ambulatory? We don't know that yet, but in unselected patients, and this is a good study from Denmark, so this is all patients in a socialised health system, and in unselected patients, the outpatient surgery rate was about 13 to 15%. And in some centres now across the country, we're achieving these rates, and if not higher, if we look at exemplar centres such as Northumbria in the northeast. However, it remains to be seen what percentage that will increase to, or whether in actual fact it may be suitable for some patients with comorbidities to stay 1 or 2 days rather than trying to get them all home on the day of surgery. I published last year an analysis of what is the current status of day case arthroplasty for both hip and knee replacement. I've just put the knee replacement cases up here, but actually, although we speak about it a lot, only 0.5% of knee replacements go home on the day of surgery. Now, as we come out of the pandemic, I think this rate is increasing because patients are keener to go home. And obviously our systems are becoming more optimised to this technique. And this is data from back in 2018 to 2019. So I think there will have been improvements since the publication of this data, which was the last available full data at the time of publication. But it still shows that there are many units where the average length of stay is still over 4 days. So there are still massive improvements for us to make for our health system and patients. But we must consider that in all of this, it's not just about length of stay, it's about improving patient care. And the ERAS concept is based on a reduction of undesirable pathophysiological responses to surgery in order to enhance recovery. And what we're after is first better care and then faster. So I think what we can learn from hip and knee is we should be mindful to walk before we run as we spread to other disciplines. The outpatient concept is attractive, but we need to get the fundamentals right, and then we will reduce length of stay as we optimise the pathway fuller. So how does this translate to shoulder replacement surgery? Well, back in 2019, we wrote an introductory article examining the current state of enhanced recovery in shoulder replacement with some colleagues at the Royal Bournemouth Hospital. We made the case that the concept of ERAS seems relevant to total shoulder replacement surgery, although it would need adapting for the specific considerations of the procedure. We looked at length of stay from HES data, and there was wide variation between an average length of stay from 1 to 6.4 days at that time for shoulder surgery. And we looked within the literature and found 13 pertinent clinical studies at that time. 7 of them looked at specific anaesthetic techniques and blocks for shoulder surgery, and 6 studies looked at whole pathway effects of ERAS concepts. And in those pathways, we found an improvement to pain scores, length of stay, complications, readmissions, and improvement to hospital cost as well, showing that in some centres, the improvement in enhanced recovery could make very valid changes. One of those articles from the US by Grosch and colleagues, and I've summarised it within this summary slide here, when they looked at an example shoulder arthroplasty and day case pathway. And obviously there's very many similarities to what we see from hip and knee replacement. We've got the optimisation and pre-admission testing and pre-operative education before the surgery. We've got to move to a regional anaesthetic technique and an ambulatory setting and catheter for the patient. This obviously fits with the ASC model within the US. The use of tranexamic acid to reduce bleeding and also the need for a drain. And then the use of non-opioid analgesics and a standard anaesthetic pathway, as well as early involvement of physio and occupational therapy, and a discharge home on the day of surgery or the day after surgery, with follow-up of physiotherapy, as would we expect. So this article is a great starting point if you're new to enhanced recovery and wanting to see what an enhanced recovery pathway may look like as an example for your patients. In terms of tranexamic acid and its transfer from hip and knee replacement, I identified it as a core active ingredient earlier for hip and knee. When I looked at the literature before this presentation, we've seen some good evidence with specific relevance to shoulder arthroplasty. The references are at the bottom. We found that TXA competitively inhibited the activation of plasminogen to plasmin in the first study, been shown to be safe and a significant reduction in perioperative blood loss and the requirement for blood transfusion after shoulder arthroplasty. And in the first study, they found that institutional experience found that if they used tranexamic acid, it helped to facilitate an earlier discharge for their patients. So it's seen that there is transfer from hip and knee as a concept to shoulder. But what I'd like to return to now, rather than some of the specifics around shoulder arthroplasty, I'd like to think about some of the process elements. I'm going to focus on this because I think all too often we focus on the clinical elements, but actually the process and logistic elements are something that we can control much more easily, especially when there isn't the evidence in the current literature to support one anaesthetic technique over another. So what is it that we cannot control? So if we look at that for a shoulder replacement pathway, or if we look at it from our learnings from hip and knee replacement, I think the thing I'd like to impress upon you is that ERAS is a quality improvement intervention. In order to make an enhanced recovery pathway work and to get good patient care, you need to match the right clinical decisions. So we need to look at the evidence base for each care component part and see if it is relevant to the specific procedure. So it may not be that all the things that we use in hip and knee replacement are relevant to shoulder replacement, and there will be research to be done in the future so that we can get the right component steps of an enhanced recovery pathway for shoulder replacement. But these clinical decisions need to be accompanied by the process and system changes. We need to do the right things in the right way. And these things we can control as teams, maybe not individually, but as hospital teams we should be able to do this. And these 3 studies here are examples from hip and knee pathways, exploring this quality improvement concept. This one here about optimising pain and mobilisation after knee replacement clearly showed that the anaesthetist tried to deal with it on their own, but it didn't work because the physiotherapists were not engaged and early mobilisation was not happening. And this one here from the Golden Jubilee showed that as they tried to improve their techniques further, actually it was culture, leadership and non-clinical factors that had the most influence on whether change happened or not. And I think this is important because if we look at the quality improvement literature, I think we can see that if you want to implement enhanced recovery for your shoulder replacement, you need these 4 key factors for quality improvement and hence enhanced recovery success. Leadership, that's both clinical leadership from the surgeons and anaesthetic colleagues and also nursing and physio to make this happen, but also executive sponsorship and leadership to facilitate the changes you may need in order to make your pathway changes. There needs to be a supportive organisational culture. So it needs to be in a hospital where this is being supported and it fits the aims and objectives of the hospital to mobilise patients early and facilitate earlier achievement of discharge criteria. You need a good data infrastructure and information system to audit your compliance to process, the enhanced recovery process, but also look at outcomes. You need to ensure that the changes you're making are actually improving care for your patients. And in many cases, you need to use a designated validated quality improvement technique to help make the changes and contextualise what you can find in the literature to your specific setting and your specific hospital. And that's important. One example where you often think you can't change things, but this is a really simple example which I think will make a massive difference. This was a study I did looking to see what extent do hip and knee replacement patient information resources adhere to enhanced recovery and surgery principles. So in many hospitals, when we looked across patient information booklets across all NHS hospitals that we could find on the internet, and only 40% of them identified their pathway to be ERAS, and only 55% of them told patients that they would be mobilised on the day of surgery. And 90% of them were outdated in terms of the bed exercises that they offered for patients, and very few of them offered any functional rehab guidance about how to progress recovery following discharge. The key bit here is mobilisation, however. If patients are told one thing by the surgeon, but then the information they receive from the hospital or the information they receive from your colleagues is not consistent and not promoting the same concept, is it any wonder that the patient won't mobilise early and be reluctant to mobilise? So I think we need to ensure that we sing from the same hymn sheet. And this is something that we can easily address within our hospitals through training, information sessions, and creating a team approach to implementation of enhanced recovery. And lastly, I know I've talked a lot about process, but it's clear across all the literature, and this is an example from hip and knee, that if you've got a pathway that's got 10 key elements, for instance, of your enhanced recovery pathway, it's important that all 10 of those things are delivered every time for every patient. Higher compliance to pathway elements improves results. And this has been found across all surgical procedures that enhanced recovery has been applied to, and was the case in this large study in Spain a few years ago. So, in summary, I hope for those of you not familiar with enhanced recovery, I've given you some background of the underlying principles and components and detailed the journey and the improvements that have been made over the last 10 years in hip and knee arthroplasty. I think similar improvements are being made in shoulder arthroplasty, and we can see evidence from the literature. And I think the future is bright in turning it into an outpatient operation for many patients. However, as I've stated before, it is not all about length of stay. We must first look at improving the pathway, so first better and then faster. And to do this, we can learn from the implementation from hip and knee replacement. We need to have the right processes and systems to support our clinical pathways. We need leadership, and also we need to work as a multidisciplinary team singing off the same hymn sheet in order to make it happen. Thank you for your attention, and as always, I'll be happy to take any questions via email or Twitter. Thank you.